All right, guys. Well, welcome to the podcast. Today we're joined by Dr. Michael Cohen. He is the founder and medical director of Belcara Health, recognized as one of the leading plastic surgeons in the nation. And maybe most importantly, he's the plastic surgery who performed two of my breast augmentations. Most recently, I think about 7 weeks ago was my last surgery. So welcome to the podcast. I'm so honored to have you on. Thank you.
Thank you, Nikki. Thanks for having me.
Yes, and as we were talking before the podcast, I just learned that you are a runner. So before we even get into the plastic surgery conversation, tell us a little bit about your experience with running.
It's kind of a funny story. Back in high school, I really wanted to play soccer, but I was probably like the last one cut from the soccer team. But while we were trying out, the track team, the cross country team would run around the field and taunt us and say, anybody that doesn't make the soccer team, you're welcome on the cross country team. Well, I took them up on the offer and I ran for close to 9 seasons, indoor, outdoor, and cross country, because you don't need very much, to do it. You need a pair of comfortable running shoes and some shorts. And every vacation I ever take, every place I ever go with friends, it's sort of kind of our thing to run together. So I run in New Orleans, in Austin, in Boston, everywhere I've been. I've enjoyed running in a new location, in a new area, and I've been doing it probably for now over 40 years. So,
Dude, it's so
yeah.
funny because running is it's like simple, but it's hard, right? It's like the simplest sport you can do, but it's so hard.
And I understand the runner's high because it happens to me 3 miles into my favorite run. I'm coming up a hill and I get this euphoric feeling. Honestly, my mindset changes, my approach to things. I feel like I wish I could just keep it with me all day long,
Yeah, you want to bottle
and
it up.
it dissipates. Yeah, it goes away after a little while, but it's a good feeling to sort of realize that.
Yeah, and that's kind of what the whole podcast is really about. Maybe running will help. It's not about PRs or, performance or anything like that. It's that high and that mental clarity and everything that you get from running that has nothing to do with the pressure to perform. So I'm glad that you brought that
Right.
up. Yeah. And then you told me you ran the New York Marathon. So tell us about that. How long ago was that?
So that was about 10 years ago, maybe a little bit more. I trained with a good friend. I enjoyed the whole, training process. He didn't enjoy it as much, but I enjoyed it. We raised money for a really nice charity, which got us in. It was a really cold day, which was a great way to start. We, peeled clothes off throughout the run. My family was there. And again, talk about like a runner's high. I became so like emotional when I saw my
Mm,
family.
hmm.
Like, I started to cry because they were there cheering me on. It was probably, mile 22, finished in the park. The only problem with running the New York Marathon was getting a ride from the park to the hotel afterwards because the city was like crazy. But
Yeah.
it was a good, first time run. And I was telling you earlier, I calculated out my mileage. It was a little bit over, well, it was 27.1 miles. And when I calculated it out, I was sub 4 for the 26.2, but it
Yeah.
wasn't official. So,
I think it still counts. I think it still counts.
yeah, thank you.
That's
Thank
Well, I wanna know how come that's the last one you did? When are you doing another marathon? We're ready. Come on, let's go.
Yeah, listen, group of nice people to run with and train with, I'll do it. I keep asking my friend, come on, let's go do it again. He doesn't want to do it. So, but I could do it on
Alright.
my own. And one of my kids said she might want to do it. So I
That's
think
always
there's
a
always hope.
good motivator. Yeah. Yep.
Yeah.
That's awesome. Well, today we are talking all about breast implants. I thought this would be an important conversation to have because, I mean, when I first came to see you about a decade ago, I probably had like maybe an A cup, which is part genetics, but part because as a runner, you just lose that fatty breast tissue. Like it happens to so many people that I know. But I
Absolutely.
think there's a part of us that, we want to be an athlete, but we also want to be feminine. But there's all kinds of like questions that we have in our head that we're going to address today. But also, like, is it okay to want to be feminine and be an athlete? Like, just all kinds of things that I wrestled with that you helped me through. So, that was 10 years ago. And now obviously I've had it done a bit again. But I think it's going to be a meaningful conversation. So before we get into like kind of the top questions that I found on Google, do you have anything to say about that? Like what you see when athletes come in to see you and like what their concerns are?
Yeah, no, these are great questions. And some of the questions you share with me. pre-interview, I just loved because this is what people ask in our consultation all the time. So a little bit about my background. I've done a lot of breast reconstruction. When I was younger, I did a lot of art. I painted and sculpted and did stuff like that. So I love, sounds weird, but I love the breast. I love the female breast. I think it's a object of beauty, admired by both men and women. And I've always liked athletes, and I've had a fondness for athletes. And we have a different practice philosophy. It's not just, throw some implants in, whatever the patient wants, large, put large in. I try to counsel patients on what works with their body. Now,
Mm,
I'm not the sole arbiter of, style and taste, but I think after 30 years, we have a lot of experience seeing things maybe that others have done or that others have recommended, and we kind of know how to do it right so that we have, I think, high patient satisfaction, safe, positive results. Because putting in large implants in certain patients would be a disaster. They end up with complications later in life. The field has changed significantly. There are newer implants made with better quality materials that hold up longer, that have been approved by the FDA, different positions now that we can put implants in. It may or may not be appropriate for a certain, cohort of patients. So some
mhm,
patients who are very, very athletic and do a lot of weightlifting and don't want their muscles messed with, we can now put these beautiful newer style implants in above the muscle, get very, very compatible with health and safety, results that move like natural breasts, that feel like natural breasts. And so we have a lot of different options, and we have a lot of different approaches. And when a patient comes into my practice, we do measurements, we listen to them carefully, we'll look at photographs that they happen to like so we can analyze their style. We'll counsel them on safety, like, wow, that implant may be too wide for your particular anatomy, and we might recommend this, that, and the other. We have ways to confirm that with patients, as by trying implants on, by looking at, in a certain three-way mirror to sort of see how it complements their body and not overwhelms them. One of my most favorite things to do is to watch a patient come out of the office dressed, so you see how it fits on their body and you see how it presents to people in the public. So it should
mhm.
be inconspicuous, it should be natural looking, and that's sort of our, approach.
Yeah, and I've loved it because I'm the kind of person who I'm like, I look to you as the expert, right? I'm like, I know that I am interested in exploring this, but I'm really looking to like what are people doing? What are you seeing? What works best for athletes? What do you think will work best on my body? Like, I want that information, but I'm sure that you have some patients that come in and they are telling you what they want, and that's probably something that you have to both accommodate, but also like kind of gently recommend you know?
Yeah, it's interesting because somebody just asked me this question earlier today. When somebody comes in and they sort of demand something or want something that I know won't work, I very politely and professionally tell them that I don't think it's a good idea. And
Mhm,
if it really bothers my aesthetic or I'm really concerned that they're making a bad decision, I might just flat out say, no, I really don't feel comfortable doing that. And patients do often respect that. They're coming
yeah,
to you because they've either been recommended from a friend or they've read about your, career and they like the reviews and they like the results that are seen on the website, Instagram, what have you. So there's already sort of like an implied trust. So if
yep.
you're saying as the expert, I mean, you wouldn't say to your hematologist, say, I don't agree with that. I don't need a blood transfusion, or I don't,
Right.
you wouldn't do that. So the plastic surgeon who has a lot of experience, who's not just the technician who will say, all right, that's what you want, we'll put that in. If I can explain to the patient why that decision might not be a good one and why my recommendation might be a better one, they'll often comply and listen and say, well, thank you. And so often, in the follow up, the patients will say, oh, I'm so glad I listened to you. This is
Yeah.
perfect. This is
Mhm.
exactly what I wanted. I'm so glad. That always, gives me a lot of pleasure.
Yeah, and you may not remember this, but we had this experience together because when I came in for my second breast augmentation, I'd asked you about liposuction, and I was like, "Do you think that this would be something that I could benefit from?" And I mean, it was an honest question for me. I'm, older, I'm aging, and I have like many women, like my stomach's not my favorite part, but We had a little discussion about it, and you let me know that that was not something that you were comfortable doing. So, as somebody who has experienced the advice, I do appreciate it, and ultimately, I think it was the right call.
Just for everybody's clarification, I'm comfortable doing liposuction, but I think in certain patients
Yeah,
that really don't have a lot of fat, you're more likely to injure them
right.
in an aesthetic way. You're more likely to create dimples, indentations, irregularities if you try to liposuction someone who really doesn't have much fat. So
Yeah.
yeah, we all have sort of, a sort of a different appreciation for our own bodies. Someone was taking some photographs this morning for a thing that we had to do, and I've never liked any photographs of me. So somebody may compliment you on a photograph and go, "I don't like it." We look at ourselves differently than other people look at us, but we should be
Yes.
doing plastic surgery for ourselves, not for anybody else. So that's another sort of principle in this practice. We're not doing it for the boyfriend or the husband. If they enjoy the results and it pleases the patient, that's we're more than willing to do it. But I don't love when there's a lot of pressure from the outside for patients to do things for others.
That's a really good point. I will say, from my experience, I think there was part of me coming in and being like, "Do you think I could benefit from this because you see a lot of bodies?" And you know what I mean? So there is like a respect for somebody like you giving advice on like, well, I think this will be helpful or not based on what I've seen rather than like somebody who doesn't know anything on the internet or, even your husband or something like that. Like they don't know what's typical, what's not. So again, like looking to you as the expert is for me was just made me feel really safe to get it. And of course, I came in with a lot of questions, which we're going to get into. And honestly, the first section of questions here was my biggest concern, and that was my running performance. Running is so important to me, and so important to so many people listening to the podcast. That was probably was going to be the make or break for the surgery. Like, is this going to impact my running? So, first of all, like, can you run with breast implants, right? So, do you get that
Yeah,
question?
yeah, no, absolutely. Again, the practice has evolved over the years. So currently, I see a lot of young moms, some of the ladies that I've done years ago, like yourself, come in. Sometimes they need more significant of a revision other than a size change or a implant device change. So
Hmm.
years ago, saline implants were placed. You would get what was called the water hammer effect. So if saline bounces against the walls of the implant as someone runs, that force is translated to the tissues, and you can get thinning of the capsule, which is the scar tissue that holds that implant in place, and thinning of the skin, such that the patients will start to sag a little bit or lose the positional fullness up above. So the saline implant was really, that was out when silicone implants were temporarily taken off the market. We used them for a decade or so, and then they've essentially disappeared. We have such great silicone devices lately that the saline is no longer really being used. But that saline implant that had the water hammer effect would cause problems with runners, athletes, and so on. So we've
Makes
since
sense.
abandoned that. We've also recently, within the last couple of years, started placing a lot of the implants in front of the muscle. So placing implants in front of the muscle, it's in a more secure space, so to speak, less likely to be pushed downward and outward, which can be
Mhm.
associated with muscle pushing as well as, say, activities like running or weightlifting and so on. So placing implants above the muscle can sometimes, especially if they're smaller implants, really not create that much stress on the soft tissues and probably be in a better, more comfortable position for running. I've just recently, within the last 2 months, done two semi-professional athletes. One was a lacrosse player and one was a soccer player. Both, as you can imagine, with the fittest bodies, just so shapely and attractive, but their breasts were small. And we
Mhm.
put in two beautiful, reasonable size, very proportionate, very natural implants above the muscle in the subglandular position with this new technique called Preservate. It's perfect. One of them got back to running in a week, and the other one was back to playing soccer in 2 weeks. Now,
Wow.
I didn't advise them to rush back to do anything that might potentially injure their results, but they were comfortable enough, and I've seen them both in follow-up since their surgeries. no complications, no problems, but they felt good enough to become active in their sport within a week or 2.
Wow.
That's unheard of. I mean, years
Yeah.
ago, it would take, people would ask, "Am I gonna be out of condition for 3 months?" No, no, no. Not really, not even back then, but now the recoveries, because we can do surgery in a very reasonable period of time. We don't give a lot of narcotics. The
Yeah.
recoveries are great. I call everybody the following day after surgery, and the
Yeah, you
operative
did.
word is sore. I'm a little bit sore. That's what patients will say, but not, "Oh, this was the worst thing I've ever done," or, "It's excruciating." Most patients are just taking, whether
Yes,
you put it
that's all
above
I
them
did.
or below,
Mhm.
doesn't really matter.
Yeah.
So it's just so much fun to see the faces afterwards about how happy patients are. But getting back to your original question, can you run? Yes, absolutely. Is it gonna hurt is it gonna hurt you if you have implants? Maybe if they're big and they're heavy, they can cause a little bit more stress on the tissues because of the weight of the implant, but the newer, smaller, more petite, more ballerina type implants or yoga type implants placed directly under the breast tissue can be so beautiful and comfortable that patients are back to normal within days, not weeks.
That's amazing.
It's true. Yeah,
Can you talk a little bit more about how you determine over versus under the muscle and then preserve, like how that's different from maybe a different technique that you would use? Because I don't think I did preserve. I think I'm actually under the muscle. So can you just talk about how you decide with patients like what's the best placement?
sure. So I like to be completely objective. Patient comes in and I start asking questions, typically about their health and well-being. If they're over 40, I ask them if they've gotten a mammogram, if there's any history of breast cancer in the family, do they have any lumps or bumps? So you want to be the doctor first, not just the aesthetic doctor. So we get a good history. We ask them what they'd like, or what bra cup size are you? So they may state A or B. What size would you like to be? And that's a really important question. Not
Mm,
because we can definitely get them that manufacturer's designation ABCD, but it gives me a little bit into their mindset. If they're an A and they go, well, I'd like to just be about a B. I want to look natural. I already kind of peg them in a category. If they say, well,
mm,
I'd love to be a D and so on and so forth, then it kind of puts me in another, sort of mindset. But
right.
then we'll go ahead and do things like measurements. So we'll take the base width measurement of the breast. So that's the breast from, say, along the curve on the lower part of the breast. You go a little bit in from the sternum, and you go a little bit in from sort of where the axilla might be, and determine the base width. That's going to be in plastic surgery, we feel, probably one of the most important measurements because let's give you just a silly example. 10 centimeter base width breast will not tolerate a 14-centimeter base width implant. You're going to have
Sure.
spillage out to the side, you're going to have crowding in the center. It's going to look too high. So
Mm,
if somebody's coming in asking for a certain number of cc's, which may have a certain base width that's higher than their little petite frame, you really, honestly, and in good conscience, need to say to that patient, "This is not going to fit." Like somebody coming in with a small, a foot, a shoe, a foot that's a
mhm,
certain size, and they want a shoe that's really too small, and they can't find something that is their size, but they're going to force themselves to take a smaller size. That big foot is not going to fit comfortably in that small shoe. A big implant's not going to fit comfortably on a more petite breast. So the measurements are quite important. Listening to them and hearing what they have to say, knowing their lifestyle. Do they work out a lot? Do they have a job or an occupation that requires them to use their chest and their chest muscles and massage therapist, say, or
right.
a firefighter? When listening to all of that, I can kind of put it together and then
Mm,
now offer them, well, we can maybe go under your muscle or we can go over your muscle. These are the advantages of going under, these are the advantages of going over. And sometimes that'll dictate which implant I can recommend. So I feel very comfortable. I'm not a what do they call it, a one horse show or one
trick pony.
pony. Feel like I don't
Mm,
do the same operation on everybody the same
yeah.
way.
No, I mean,
You
I know that. Yeah. I mean, because I feel like, I've heard so much about over the muscle. I'm so happy with the results of my surgery, but I never would have thought we would have gone under the muscle. based on, and I don't know, maybe that's because I had the surgery already before and that's how it was done. But but I also feel like you made the decision based on my lifestyle and,
Yeah.
my particular
So
body dynamics.
this is such a big topic that it takes up an hour or so in our national meetings of this sort of debate, over or under, over or under. Again, I like to be very open minded about it, and I can just tell you, in my 30-year career, when I did, for the most part, for the longest time, under the muscle, I got, without bragging, I got great results with low complications, and patients had a lot of pleasure and happiness, and it created a lot of natural appearing outcomes. And if
Mhm.
you sort of overdid it a little bit because that's what the patient wanted and it was reasonable and compatible with their frame and so on, it can look really notable. So it's not all or nothing. It's not like, well, if you put it under the muscle, it looks too natural. If you put it over the muscle, it looks too fake.
Right.
Again, with a lot of experience, like I have, you can tailor it. And again, we have such a high satisfaction rate when it comes to size, position. Thank goodness complications are low. It just it works out. And every time you get a successful outcome, it's confirmation that, wow, that was a good decision. I'm so glad I made it.
Yeah.
If somebody's had implants under the muscle for years and they don't have any problems like what they call hyperanimation, where if you squeeze your pec muscles and you see the implants move back and forth,
Right.
that's, you keep it under the muscle because it's worked well. If someone's ultra, ultra thin and they have really little breast tissue or fat, that's somebody who you may want to really consider putting it under the muscle. If they have a little bit of soft tissue, a little bit of fat, a little bit of, pretty youthful breast tissue that hasn't, involuted after pregnancy, you can put it over the muscle because some of these newer implants are so compatible with that position and have been really designed for that subfascial or subglandular position, which is over the muscle. It works well. So I've been pleased with, I would say almost all the decisions that we've made. And if for whatever reason the person doesn't like it in that position, it's not too difficult to, at some other point, take it out and put it in a different pocket.
Do you ever go into surgery thinking you're going to do one thing and then do something different?
Rarely. I mean, like
Rare.
a
Yeah.
pilot, I have a son who's a pilot. You do, pre-flight planning and check the weather, you check the map, and you check in with, air traffic control, all that sort of stuff. You have a plan. I review almost all of my cases the night before, like a
Mm.
quarterback would do, at a football game,
Yeah.
and I sort of plan it out in my head, and I have like a little video in my head of what I'm going to do. Now, that's not to say that I can't react to something that may seem different or unexpected, and we do that all the time. But
Yeah.
like when you're in school, you don't want to be taking a test and changing your answers at the last minute or second guessing
Right.
yourself. Because
Right. Right.
9 times out of 10, you're gonna screw yourself up. But
Yeah.
so we have a game plan. We typically execute it. It allows surgery to go efficiently, not necessarily quickly, but efficiently, so you're not wasting time. I learned this from a really famous plastic surgeon about 30 years ago, where he went to Japan and he learned from industry how to do things in a very efficient, economical way. I mean, economical when I'm talking about movements of the body, which is a very athletic concept,
Hmm.
where you're not going to waste energy, motion, decision making, doing things, off the cuff. You have a
Right.
plan of action.
Hmm.
You can go from right to left. You get your instrument, you do your thing. It helps patients recover quicker because they're under less anesthesia, less tissue trauma, and you execute things in a very precise, determined way.
Okay. All right. That makes a lot
Yeah.
of sense to me. So, in talking about running performance, I did ask, I have a couple runner friends who have had implants. So I wanted to get their perspective on, if it affects running performance or what their experience was. Personally, I actually, when I got my implants, 10 years ago, I remember I was training for Chicago. I actually PR'd by 10 minutes. So, I mean, did
Right.
not affect my performance whatsoever. I don't know that it made me faster. Maybe it gave me more confidence. I don't know. but it did not affect my performance. So that's my experience, and that seems to be the consensus. Implants have not affected me at all with my running. Implants have not affected my working out. So it seems to be a non-issue. If and these are people that are your patients, also, I should say as well. Yeah, and so those concerns seem to be a non-issue. Can
You
they slow
get,
you
like, once
down?
again,
Is it hard?
if the implants are too big or they're sort of up in the axilla because somebody chose too wide of an implant. So, just for the audience's understanding, some of the companies make five different widths of implant, everything from a narrow, more projecting implant to a very wide, flat implant, and then, several in between. One of the other companies has three different widths. So you want to match that up with the patient's base width of their breast. So the footprint of the breast, you want to have something plus or minus a couple millimeters on either end. But something that's too wide is going to be up in the armpit. It's going to be hard to shave. It's going to be hard to
Yeah.
run. So the arms going back and
Yeah.
forth might rub against it. Again, this is why you
Yeah.
have to go to the expert.
Yeah, nobody wants any of those things. That sounds terrible. Okay, and so the next kind of section we're going to is questions about movement and balance and things like that and how it impacts. I mean, again, this is all performance related, but specific questions, as to do they bounce when running? How do we prevent them from moving into a place where we don't want them? Concerns about that. From my experience, that has not been, anything that I've had to deal with. I will say this time with this particular implant, I have needed a more support than with the last one because they're a little bit bigger. So, and I'm still only 7 weeks post surgery, so I am supporting them a lot more. But with the right support, no issues. So, what do you have to say about movement and how to prevent any kind of shifting that we don't want? Are there concerns there?
Right. So typically when we put the implants in, we discourage massage and movement in order to allow this capsule or the scar tissue to kind of form around it. So scar tissue can either be very, very thin and light, which it often is, and that's what you're hoping for, or it could be very, very thick and problematic. That's called capsular contracture. That's sort of a
Mm,
separate issue, and that has to be addressed often with some additional surgery. Fortunately, it doesn't happen very often because we do a lot of things to prevent it in surgery. So there are principles that we follow that we've learned from our colleagues over the many years, things that you do in surgery to avoid capsular contracture, specific irrigations, antibiotics, changing gloves, using this funnel to be able to put the implant in without having to touch it, making sure there's no bleeding. So all of these things decrease that potential incidence of capsular contracture so that you don't end up with a hard capsule, you end up with a thin capsule. The thinner the
wow.
capsule, the more you're going to actually feel that implant through a person's skin. So if a woman feels their breast and it feels nice and soft, and they have a nice soft implant, they typically have a pretty thin capsule. That capsule is like, I always sort of say it's like a slit within a skirt. It's sort of an inner lining, and that's going to be really what's going to support that implant. So there should be a little jiggle and a little bounce because that's what the
Mm,
natural breast does.
right.
If someone's very young and they have a lot of elastic tissue, that elastic tissue will hold the implant in place. That's one of the advantages of this preserve technique because you put the implant in and you maintain all of the ligamentous structures around the breast that will hold that implant up and prevent it from dragging the skin down. So it's not in direct contact with the skin. It's really more supported by a nest of ligamentous structures that are going to hold that
Mm.
implant. So
Shoot. So
there's a
yeah,
little bit more. Yeah.
because we didn't talk about the Preserve, so let's definitely talk a little bit about that and how it's different from other implants. Is it different in terms of how you do the surgery and like the size that you can do? Are those different?
So let me summarize. So the preserve isn't the implant; it's just the technique, and it's done
Oh,
through. Yeah. So the Motiva implant is used in this preserve technique,
okay.
and preserve is really essentially a device that creates a small channel from the incision under the breast. So it's a really tiny, about 2.5 centimeter incision.
Hmm.
The channel is provided underneath the breast tissue, so over top of the muscle, underneath the breast tissue. We place a balloon in this channel, fill the
Hmm.
balloon for about 10 minutes. with air. Go to the other side, do the same thing, create a channel, put the balloon in, fill it up with air, go back to the other side, take the balloon out, and then we insert through a funnel, which looks like a pastry funnel, this implant, this Motiva implant with a very, very soft, flexible structure into that little pocket and close it up. And it's almost that simple.
Wow.
Now, we're limited in size. So that's why we call it the ballerina breast, the yoga breast, the
Okay.
micro breast,
Okay.
because it's for the ultra athletes that have really nothing, that want a little bump up. They want to feel a little bit more feminine. They want to have a little bit of something to fill a bra and a t-shirt, but they don't want to be big and they don't want to be noticeable and they don't even really want people to pick it up.
Yeah.
So you're limited. You can't put in the size implant that we would put in other people, or say, because you've shared the implant that you have wouldn't necessarily be compatible with this device and this technique because the channel has to be narrow. The implant has to be able to squeeze in. It's almost like giving birth, but in reverse. We're pushing something in through a small channel versus allowing it to come out.
Yeah.
And patients that we've done have been very pleased. The interesting about this technique is you can do it under local anesthesia with
Wow.
sedation.
What?
Patients, we have videos. Patients are animating already in the recovery room. They're moving their arms about. Some doctors are even sort of encouraging them, go out to dinner with your friends and, go out on the town. I think anybody that has surgery should probably go home and rest for the day. And then, the following day they can go out and show off. But
That's amazing. So the recovery is like so much easier probably.
it's, yeah, I mean, it's, it's really a lot of fun to do. If you see the smile on the patient's face in the recovery room,
Right.
because again, it's not overwhelming. And this is really intended for patients who say, all right, I'm a runner, I'm an athlete, I don't want big implants, I don't want anybody to notice it. I know I'm thin. And so if you put something small, very compatible with nature, and just have it sitting directly under the breast tissue, hardly anybody's going to, get worked up over it, and it's going to look beautiful. So
Yeah.
I think it's a great thing. Yeah.
I mean, it sounds amazing. Can you talk a little bit about the recovery with something like that versus, a different kind of procedure for the implant?
Sure. Again, with vast experience over the years and calling just about every single patient the following day, the operative word is sore. Whether you do preservé or whether you do subfascial or submuscular augmentation, everybody says sore. But within a couple of days, they're feeling better. I don't know that anybody I've ever done surgery on has regretted that they did it.
Hmm.
Really only maybe 2 or 3 patients I could think of in this long, practice experience have ever said after a period of time, "Just take them out. I really don't want it," in the short term. Now,
Yeah.
over the years, women will have them taken out for one reason or the other. They just don't like them anymore. It's not their style. The original implants put in by somebody else years ago were too big. They've had weight fluctuations, or they've decided to do some new activity and they don't want the large implants. So there are different reasons why people have their implants taken out, but when someone makes the decision to do it, there's a very high satisfaction rate, especially if you can give them what they've envisioned and what they've looked for, and and what they've ever always dreamt about.
Yeah, I mean, I think the recovery part of it is not it's not as bad as you think. Honestly, the worst part for me was probably the medication, like having to take the painkillers, which I only did for like a couple days, but it wasn't the surgery or anything like that. It was just the medicine that I was on was hard for me for like a week, maybe a week.
Yeah.
So,
There's something that we've learned from orthopedic surgeons. It's called ERAS, extended recovery after surgery. So it's a combination of several medications that patients typically start 2 hours prior to surgery, and then they continue it afterwards. And what it does is it takes away the need for narcotics. It allows them to typically get their pain relieved with just Tylenol.
mhm.
And again, most patients these days are saying, "Yeah, that's all I did was take the Tylenol and I was fine."
Yeah.
And it's amazing. I'm always amazed when I call somebody and they say, "Yeah, it wasn't so bad." I'm like, "Really? I'm glad to hear
Yeah,
that."
it and the it was a lot different than the first time I did it. The medication or whatever I was on, it was a lot like, the process was a lot different. I definitely noticed that. And I can't remember the recovery all the way back then, but this was pretty easy. I think the week 1 week after was tough, was really tough, but that was it for me. So I'm sure with the Preserve, it's not even you're probably not even taking all that medication or anything, right? Or are you?
No. Again, based on our, experience so far and the patients that we've done have been very happy with it, haven't needed a lot of haven't had to call in one extra prescription, said they just relied on Tylenol, so it's
Yeah.
great.
That's amazing. So, can you talk a little bit about the restrictions after surgery? Because I know everybody wants to know how long am I going to be out of running, and I know it's going to depend on what procedure you do, but maybe you can talk about all the different recovery timelines.
Yeah.
Getting back to sport.
Yeah, so I did indicate that these 2 most recent, really professional athletes, both got back to doing their sport within 3 weeks. So we learned a long time ago in plastic surgery that within the first 2 or 3 weeks, when you increase your heart rate and blood pressure like you would with exercise, you have the potential to break off, like a little clot that may be associated with, some of the surgery that you did. Not blood clots that travel to your heart and lungs, but if you've cauterized or achieved a bloodless field in surgery, not to be too graphic, but a little blood clot could break off and you could get some bleeding postoperatively if the blood pressure was up or the heart rate went up. So that's why we really discourage exercise in the first week or two and maybe even three. Again, patients push it. I have to say, I can't really just give up on the recommendations and say, well, you're an athlete, so go back sooner. I really do
Right.
have to hold to the recommendation. Please try not to do anything too strenuous for 2 to 3 weeks. But again, some people have to get back a little bit early to their job or whatever, or the athletes want to get back to training earlier and they do it, and thank God, so far everybody's been okay. But the
Wow.
the the rule is typically, 2 or 3 weeks to keep your heart rate and blood pressure low. And every once in a while, somebody wants to stretch a little bit or wants to, walk, which would be encouraged, but not necessarily walking for heart rate increase, but walk to just kind of keep limber and keep the joints flowing.
I'm laughing because that is not why I thought I wasn't working out. I mean, I did a little bit know that it was the heart rate. I literally thought my implants were going to fall out of my stitches.
Yeah.
So it's not at all about like the movement of the implant or anything like that. It's all about the heart rate.
If a woman had a very supportive sports bra on, they can do things earlier. But again, it's really the heart rate and the blood pressure thing that we most worry about. And, every once in a while, every year or two, somebody calls and they're out from surgery 3 or 4 or 5 weeks and, they develop a little bleed. It's unusual, but it's often associated with, well, I just came in from running and I took a shower and I bent over to pick up my towel. And that was one story I heard many years ago. Doesn't happen often. It really
Yeah.
doesn't.
What well
And
what so what happens? Yeah. What do
well,
you do?
they called and said, one breast was getting larger than the other, and I immediately knew what that was, and took him back to the operating room, took out the hematoma or the collection of blood, made sure that there was no more bleeding. It typically stops by the time you actually get into the operating room. Cleaned it out, put the implant back in, and they were no worse to wear.
Uh,
It's a inconvenient and it's
yeah.
a bit of a hurdle to get through, but we recognize it, act upon it immediately, and it's really important for patients to have that addressed right away because
Mm.
again, I've heard all kinds of disaster stories where somebody said years ago they had that happen and their doctor said, "Oh, it'll just get better." That blood in there can actually create more scarring, which so we really want to get it out and take care of it and get them back to normal. Again, fortunately, it only happens once or twice every, year or two, and that's about it.
Wow, okay, because this is so funny. You don't understand, like, the scenarios I was making up in my head. I was like, if I run, they're gonna end up in my armpit or, like, they're just gonna shit maneuver some way. My husband was so concerned I was gonna mess them up. He called your office, like, and to tell on me a couple times to be like, "Alright, did you tell her she was allowed to do this?" We were so worried they were gonna, like, shift in some, like and I was gonna be like a mutant.
You're gonna laugh. I read an article in the New York Times many, many years ago, and this is the truth because I've read the article. There was a woman in Australia that was bungee jumping a couple of days after her breast augmentation surgery, and because she was upside down and the force was so great, according to the article, it said both of her implants came flying out. Now, I've never heard of that happening ever. I would warn patients, don't go bungee jumping, 2 days after
Right.
surgery, but fortunately, there's
God,
no
no.
facilities near.
You got wait till I tell my trainer. Okay, I was telling him, I was like, "We can't do that. I'm afraid they're gonna end up in my armpit." I was oh my gosh, that's so funny.
We we
But I'm
we we close these wounds in, many layers, and we secure things to the fold. We also do something a little bit unique. We want to keep that scar directly in the fold so no one can really see it. So there's some special sutures that we've learned. We learned this a long time ago from a Swedish doctor, how to secure that inframemory fold so that you don't see the scar and the implant doesn't travel below that fold where now the scar is going to appear on the breast. So again, some very special techniques that we've learned over the years.
well, I think maybe I had read horror stories about what you're calling animation. Like, what is that? Like, when does that become an issue? And what do they mean when they say that their implants go in their armpit? Like, what do they literally mean in the armpit?
So, right. So everybody, this is what's really so hard to express. Everybody thinks that, well, plastic surgery is a commodity. Everybody can do it. Anybody can put breast implants in. Well, many people can do it, but they don't always do it right.
Mhm.
So the pectoralis muscle starts out at 6 o'clock on the chest, at 6 o'clock, and it runs all the way up onto the clavicle and it extends to the humerus. When we put an implant in under the muscle specifically, we cut from 6 o'clock to about 8 o'clock to allow the muscle to rotate slightly. So the bottom of the implant is sitting directly under the breast tissue, and the top of the implant is covered by the muscle. That's how you can get a very pretty natural soft slope and a nice result. If the muscle is cut too high on one side and not enough on the other side, and if you're a practitioner that doesn't know what you're doing, you can have sort of asymmetric pull or unequal pull, and that's why the breasts look like they're sort of kind of bouncing all over the place. Because of sort of this evolution into placing implants now above the muscle, I've asked many of my patients who come in, who I did many years ago when 90% of us were putting implants under the muscle. I say, do me a favor, put your hands on your hips and squeeze for me. And when they do that, or you can put your hands in front and push like this. What you do is
Right.
you engage your pec muscles and you should see a little bit of motion. Almost everybody that does it has a little flicker of motion. I ask them, and I have a couple videos where I've taken so I can show patients, does that bother you? They go, no, it doesn't bother me. I don't think, other than maybe one person years ago, anybody has ever come in specifically bothered by this little bit of animation. So again, just to summarize, if you do the operation under the muscle appropriately, you really won't see animation deformity and it won't be enough to bother you. If
Yeah.
for whatever reason you've been to somebody who doesn't really, execute all of the principles as we know them, you can have asymmetric pull and a lot of animation. So they call that hyperanimation deformity, which can be, a little bit disturbing, especially if you're at the gym or you go to lift a weight or you go
Okay.
to, say, maybe shake somebody's hand, you see the breast move. There is a way to
Okay.
fix that. We can take that implant out, put the muscle back down, and put the implant in a new position and
Mm,
solve the problem.
that's good to
So
know.
it's not insurmountable. Yeah,
But so, and this isn't an issue for, the running population specifically. I mean, I do like to lift to support my running, but there is a little bit longer of a recovery period if you're going to be lifting weights. So, especially if you're targeting the chest area, right? Is that because you can cause the implants to shift if it's under the muscle?
absolutely. So people that are predominantly putting them over the muscle now complain about this and say that they're concerned about hyperanimation deformity. They're also worried about displacement. So if you have an implant sitting under the muscle contracts and engages. It pushes against the chest, and it can force the implants down and out. We call that malposition or lateralization or bottoming out or lower pole expansion. So all of those things can occur more frequently when the implants are under the muscle. Now,
Hmm.
one of the ways to prevent that is to say to the patient, please don't do any chest exercises for a period of time. I like to say, 3 to 6 months,
Yeah.
actually 3 to 4. really 3 to 4 months. Most women really don't need to build big pec muscles. Men like them
Right.
because they look good in a shirt.
Hmm.
You are engaging your pecs when you do arms and when you do back and when you do other things. So just concentrating on flies and, you know, incline bench press and that sort of stuff is really not necessary. I personally think for, athletic women, you can probably do other things while the tissues are healing. Again, if you've chosen to put it under the muscle.
Yeah.
So there's ways to avoid it. And again, we
Yeah.
rarely see it.
But 3 to 4 months, and you're free to do whatever, really, right? I
Yeah,
mean,
because
at that point,
because
you're healed.
Yeah, because there's capsule that's formed around that implant, and by, you know, 3 to 4 months, that capsule's pretty stable, and you're not gonna get a lot of lateralization or malposition. So, our regimen is typically to see patients a couple of days after surgery, make sure there's
Mm.
no problems. I'll
Right.
see the patient about a week after that, as you know, which is at about 10 days.
Mhm.
Everybody is usually really happy and elated, and I always laugh. I say, "If you're happy now, wait till it settles and it looks really pretty. You'll even love it
Yeah.
more." So
Yeah.
it's exciting to see what patients are happy on that first visit. Then I'll see them back at 6 weeks, and then I'll see them back at 12 weeks. So 12 weeks is
Mm.
3 months, and by
Mhm.
12 weeks, if that implant's in a good, stable position, I think we're golden. When patients come and say, "Yeah, I heard it takes a year for breast implants to, fluff or settle," or whatever they wanna call it,
Fluff.
I don't think that, is necessary. I don't think it takes that long. I think by 3 to 4 months, if they're in a really good position, you're really good to go.
Yeah, I mean, I can't wait until I can not wear a super supportive bra, which I feel like I'm already, like, breaking the rules there, but that's my only thing. It's like, "Oh my god, no more harnesses."
Right.
But
Well, this is the
yeah.
best this is the best time of year because I've always said to the patients, "Look, if you can if you wanna take your bra off and wear something really pretty, a sundress or, something a little more revealing, bathing suit even, you can do that. But at night, post-surgery, put a sports bra on, go to bed, with a bra, wear it when you're back at the gym. But if you're going out for the evening, you wanna look pretty, you wanna go without a bra, that's where you did the operation. So,
Exactly, yeah.
enjoy it now. Not
Yeah,
gonna hurt anything.
exactly. Exactly. I have a question. I don't even think I put on the thing. What about sleeping? Can you what if you're a stomach sleeper? I'm so worried I'm gonna smash a like, does it matter
I
how you
think
sleep?
I think at 6 weeks out, you can almost do anything.
Yeah.
Early on, you don't wanna displace things by, having, say, a pillow under your breast, pushing it over. You kind of wanna
Right.
lay on your back for a while with a little bit of an incline because of swelling. So we encourage patients to sort of sleep on their back with the head of the bed elevated just slightly for the first couple weeks. But again, capsules forming by 6 weeks. There's a little bit of support in there. You just wanna be, gentle and not too aggressive with pushing in one direction or the other. But,
Okay.
I can't say that other than a patient who went out and started doing flies and inclined chest and all kinds of stuff and then said she didn't realize that she wasn't supposed to do it, I've really never seen a problem where breast implants have drifted out too far very quickly. I mean, as
Yeah.
long as patients are being careful and watching what they're doing in the early period, and they're usually super, super compliant, you're not going to have any problems.
Okay. Alright. Well, then I will stop worrying about it.
Yeah, no,
Wanna protect these, you know?
for you.
Yeah. All right. So I mean, we hit pretty much all the questions in our conversation here about, where do we place them, the sizing, you know, things like that. I do have comments from runners, but all the questions that we talked about, no one has really had any of the issues that, we're kind of discussing right now. And everybody seemed to be able to get back to sport pretty quickly.
Yeah, yeah.
So,
I would
no
just say,
concerns.
for people, for women that are fearful or just don't like the look of a large or noticeable breast, there are so many beautiful ways. And again, this is sort of the evolution. This is where I think we've always been on this page, but now it's even easier for us to accomplish these natural, pretty results. Again, kind of a conservative person. I like a pretty natural result. I mean, you've seen women walk down the street, clearly had a facelift, look windswept. It's not, in my opinion, an attractive result. But you've seen other people that look very pretty. They look refreshed. I wonder if they did anything. I think that's what we want to try to do with breast surgery often, to have it sort of fly under the radar, be really subtle, make the person happy inside, and not necessarily, display to the world, oh, look what I've just done.
Yeah. Yeah, I mean, there and I was so excited to see how far the, whole industry has come, like, when I came back in, and the press survey, like, I think if I mean, I don't know, just because of the size that maybe I wanted or needed, but I think if I had the option, I would have opted for that. It just sounds so the recovery sounds so simple and, not being under sedation. It sounds like a really great option, and I'm sure that there will be advancements there as well.
It's not for everybody, so we
Yeah.
always encourage patients, and, we'll evaluate you, we'll tell you whether you're a good candidate or not, and if you're not a good candidate for Presbay, there are plenty of other ways to do it that are almost as good, or as good, I should say, for that particular person. Under the muscle works great for you. Over the muscle in the subfascial position, it's great for some people. If you're a little A cup and you want a small improvement, Preservé may be ideal. There are indications and indications to each of these procedures, but again, we're honest. We'll tell the patients what we really think they need, and 9 times out of 10, they agree with us and move.
That's awesome. So if people are interested in, exploring this a little bit further, what's kind of the first step? What should they be prepared to, when they come in the office, they make an appointment, like what should they be prepared with, you know, in terms of
Yes,
exploring it?
great question. Yeah, yeah. So we have a great coordinator. So typically, if they call the office, Belcara Health, look this up on the web or what have you,
Yeah, we'll have a
they
link
would,
in the show notes.
yeah, they'll speak to one of our coordinators. Jessica is wonderful, very
Mhm.
experienced, been doing it for over 15 years, and she asks the right questions. She's not a physician, but she really knows the questions to ask. Kind of gets the patient prepared. May ask questions like, "Can you hold a pencil under your breast?" If they can, it may indicate that they might benefit from a lift. So, she'll move in those directions and sort of give them information, financial information, sort of answer their questions about how long would the surgery be and what's Dr. Cohen or Dr. McMillan's availability. And, so she sets up the consultation. They'll come in relatively well informed, and I'll, of course, meet them. We'll try to get comfortable. I'll, ask them some health questions first. Then we'll do a brief exam so I can just measure the anatomy, look for asymmetries, because, by the way, most women are asymmetric. The nipples aren't exactly even. The breast size is typically one is a little bit bigger than the other. So we look for these asymmetries, point them out. We don't take any photographs the first day or anything like that. We just sort of get a lay of the land, so to speak. And then I can hopefully make a reasonable recommendation in a short period of time. We'll often allow them to go into a sizing room. So even though
Hmm.
it's not a strict criteria, we'll let them try implants on in a thinly lined bra that we have with a light top, so you can sort of see how that improves the shape. We'll take pictures sometimes with them holding up a little card that says 250, 350, cc implants, so they can maybe even take them home and show them to a girlfriend or husband or boyfriend or whatever.
Mhm.
And they'll have a little something that they can ask other people's opinion if they so wish. And many of the patients come in already sort of planning to pick a date for surgery. They pick a date for surgery. They'll be given another appointment to come in for a pre-op where the nurse will educate them about what to expect before and after surgery. Talk to them about medications. Talk to them about things they should or shouldn't do prior to surgery. They'll get a date, a time, and off to the races.
That's
Yeah.
exactly right. So is it like when they come in for booking, are they looking at probably scheduling in what, like 2 to 3 months, getting in and out?
I love breast surgery, so I always try to make room. It's funny when you go to see a doctor and they say, "Well, waiting list is 6 months." So
I
I think
know.
some of that is
Yeah.
is pretend, and it's creating this mystique that this person's so busy. But we have a lag period where patients can't sign up tomorrow, but I'll often fit them in. Breast augmentations typically take us a little bit less than an hour. So I know how bad people want things, and I know I'm get impatient when I want something. So I make it happen. It can
Yeah.
happen in a short while, and sometimes patients are long-term planners. They are off during the summer with kids or whatever, and they go, "All right, I'll do this in September, or I'll do this around the holidays," or So, we like to flex and accommodate the patient's needs.
Yeah, that was definitely my experience, and I was a little bit trying to plan around vacations or plan I mean, even planning for vacations. I remember, like, we had something in March, and I was trying to be like, "Do I wanna do it before or after?" So there's some considerations when you come in, like, about timing that you might think about. And travel, I mean, you can travel after surgery, right? There's no real
Yeah.
restriction on flying or anything like that, right?
No, I mean, often if somebody come in from a distance, and they've taken a plane flight, you don't want them jumping on a plane again for fear of blood clots in the legs and all that sort of stuff. But
Yeah.
again, most of the surgeries are typically within an hour. A breast lift may take us about 2.5 hours. I just saw a really lovely patient. She's a friend, somebody I operated on again, maybe 15 years ago, did a breast reduction. Her son is getting married in the fall. She wanted to look pretty in a dress. Her breasts were really large, and she looks so good right now, and she's so happy. It's smaller, uplifted. She could go without a bra right now. So it's very gratifying.
That's awesome. Well, I really appreciate your time. I love having you as my doctor. You're just so nice and you answer all my questions. And again, like I'm somebody who wants an opinion and you're always so accommodating. So I appreciate you and I look forward to seeing you probably in a couple weeks for my follow up. But thank you for answering all my questions.
You're very welcome. You're so sweet. The feeling is mutual, and I was so excited when you invited me because I love athletes. I love athletics myself. I'm in the gym 6 days out of the week, doing something. So I
Yeah.
get the mindset. I think one of the harder things you didn't ask me, but the recovery, getting patients to hold off on all of this stuff is like torture.
Yeah.
I had a hernia surgery a couple years ago, and he told me to be off for 5 weeks, and it was like I was counting the days down because nobody wants to decondition. Nobody wants to have to
Yes.
take a step back. So I get the mindset. That's sometimes the hardest thing to overcome.
I mean, that's such a good point. That it is the hardest part because you work so hard and you're afraid you're gonna lose it all. But yeah, no, I knew you were excited when I mentioned it. I was excited that you were excited. But yeah, look forward to seeing you
Be
soon.
well.
All right.
All right. Thank you.
Thank you.